Welcome. My name is Annie Rogers, and on behalf of the ADDitude team, I'd like to thank you for joining today's ADHD Experts presentation titled Integrated Care for Children with ADHD, How to Form a Cross-Functional Care Team. As you know, ADHD is one of the most common and complicated disorders in children. Overlapping conditions, diverse symptom clusters, and barriers to care often complicate both diagnosis and treatment. However, when professionals join forces to provide a team-based approach to patient care, the evidence shows improved outcomes for all. In today's webinar, we will introduce the integrated care model and explain its benefits for patients with ADHD. We'll discuss how parents, providers, behavioral care managers, and school officials can all work together to improve care for children and adolescents. We're fortunate to have three experts leading today's presentation: Dr. Sheryl Morelli, Leslie Graham, MSW, and Dr. Douglas Russell. Dr. Sheryl Morelli is a pediatrician and a professor at the University of Washington School of Medicine. She received her medical degree from Wright State University and completed her pediatric residency at the Wright State University Integrated Pediatric Residency Program. Dr. Morelli currently serves as the Chief Medical Officer for Seattle Children's Care Network. Leslie Graham, MSW, graduated from the University of Washington and is a licensed clinician in the state of Washington. She has spent the last decade partnering with UW and Seattle Children's medical teams to develop a pediatric integrated behavioral health program in South King County, Washington. Dr. Douglas Russell is a child and adolescent psychiatrist and assistant professor at the University of Washington School of Medicine. He received his medical degree from Jefferson Medical College and completed both his psychiatry residency and child psychiatry fellowship training at the University of California, Los Angeles. Before I hand over the microphone to today's speakers, I have just a few housekeeping items. Those of you tuned into the live webinar may submit questions to our experts at any time by navigating to the text box under the video player. To download the slides, click on the Event Resources section of your webinar screen. And if you're interested in the Certificate of Attendance option, look for instructions in an email you will receive about an hour after the live broadcast. If you are listening in replay or podcast mode, visit ADDitudemag.com and search podcast 411 to access the slides, the webinar replay, and the certificate of attendance option. If you support the work we're doing here at ADDitude to strengthen the ADHD community, we encourage you to visit ADDitudemag.com/subscribe and sign up for ADDitude Magazine for your family, or to share with a teacher, loved one, or member of your collaborative care team. Finally, the sponsor of this webinar is Brain Balance. Brain Balance is an integrative cognitive development program designed to help kids, teens, and adults with ADHD, learning differences, anxiety, and beyond improve focus, attention, and behavior. Brain Balance creates a customized plan based on your child's needs to support their social, emotional, and academic growth. An exploratory study with Harvard's McLean Hospital found that Brain Balance programmed to be as effective as low-dose stimulant medication in alleviating ADHD symptoms in children. Visit brainbalance.com to learn about Brain Balance today. ADDitude thanks our sponsors for supporting our webinars. Sponsorship has no influence on speaker selection or webinar content. So without any further ado, I am so pleased to welcome Dr. Sheryl Morelli, Leslie Graham, and Dr. Douglas Russell. Thank you all for joining us today and for leading this really groundbreaking discussion about collaborative care.
Thanks, Annie. Hi, it's Sheryl Morelli. I'm going to start off today. So good morning to those of you on the West Coast and good afternoon to everybody further east. I'm going to start today by talking a little bit about what integrated care is and why we feel primary care is the ideal setting for this approach. And then I'm going to go into a little bit about how integrated care is delivered from my perspective as a general pediatrician. I'll then hand off to Leslie, who's going to talk about it from her perspective as a behavioral health care manager, followed by Doug, who will talk to us about it from his perspective as a child and adolescent psychiatrist. Doug will then hand it back to me to cover some of the benefits of integrated care. Leslie will come back to talk with us a little bit about how to get started with integrated care, and I'll wrap us all up by talking about some key take-home points. But throughout the presentation, we are going to use a case of a young girl, Sarah, who's an 8-year-old, to illustrate a lot of the concepts that we'll be talking about throughout our presentation today. But before going right into what integrated care is, I feel like it's important to talk a little bit about why are these care models being developed and tried? So what's wrong, right? Why is what we're doing current state failing? So as Annie mentioned, ADHD is really common. So in the latest information from the CDC, the prevalence of ADHD is about 3 to 5% in preschool age kids and a little bit higher in school age kids at about 5 to 8%. And as many of you know, comorbid conditions are really common for kids with ADHD. So at least 6 in 10 kids with ADHD have one other either mental, behavioral health, or emotional disorders such as learning disabilities, depression, or anxiety. And despite ADHD being super common with very frequent comorbid conditions, only about a third of kids with ADHD are currently receiving the indicated evidence-based treatments. So why is that? But there are a lot of barriers to care, actually starting with pediatric training. So for any of us in primary care, especially those of us who trained more than 10 years ago, we really received inadequate training in medical school and residency to address behavioral and mental health concerns. We really focused our training on physical health. We're really good at that, but we really have a lot to learn about providing good care for behavioral and mental health conditions. Next, there's a lack of pediatric services in many communities, and this can really range from anything as basic as good parenting classes all the way to a little bit more advanced treatments such as cognitive behavioral therapy or parent-child interactive therapy. In addition, there is a significant lack of pediatric specialists almost everywhere throughout our country. Definitely lack of pediatric adolescent psychiatrists, a lack of child psychologists, and in particular, a lack of developmental pediatricians who frequently would be involved with kids with ADHD and many of their comorbid conditions. And despite there being some nice improvement in this area, there still is a lack of understanding or a stigma around behavioral mental health conditions, especially in certain cultures and communities. And finally, there's a significant cost associated with making accurate diagnoses and getting evidence-based treatment for ADHD. It can take multiple evaluations and appointments with several different specialists to get to an accurate diagnosis. And then the treatments can be quite lengthy. So there can be 10, 12, 16 sessions at a minimum to really engage and get good care for ADHD. This leads to a lot of direct costs, not always covered by our insurance, as well as indirect costs associated with missing school, missing work, childcare, transportation, et cetera. So that really has led many to look at how can we do this differently, which leads me to, well, what is integrated care? So integrated care, I really like this definition. I'm going to read it to you because I think it's really impactful. It's the care a patient experiences as a result of a team of primary care and behavioral health professionals working together with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population, such as individuals with ADHD. When we integrated care is all in one setting. So all of these individuals are actually usually physically located together. So the primary care provider, the behavioral health care manager, and the psychiatric consultant are all in the same space with doors opened. So we have open lines of communication. We're using the same systems. So we have the same scheduling systems and we have the same documentation systems. So this really allows for consistent collaboration and communication at the system level, the team level, and the individual level. So then why is primary care the ideal setting for this type of care? Why not do it, as an example, in the psychiatrist's office or the behavioral health care manager's office, in the psychologist's office? Well, primary care is where many of you are seeing us already. So we have regular and frequent contact with patients and families, typically starting from birth, and with some families even prenatally. So we, doing prenatal visits, get to know you, meet and greets. This allows us to develop really longitudinal, in-depth, trusting relationships with patients and families, which really provides an ideal foundation for these types of integrated care models. Primary care practices are often well-versed already in providing team-based care. In addition, we are some of the only usually medical professionals who are really looking at the whole person. So unlike specialists who really focus on their niche area, we really are trying to look more holistically at patients and families, which really helps support these types of care models. And finally, primary care is a really good gateway to other services. Primary care practices are usually really aware and informed of the other services that are available in their communities. We often already have nice relationships with many of these services, so we really are a good connection point to the services out in the community. So that's just a little brief about what integrated care is. We're going to go into much more in depth about it, why primary care is an ideal setting for this type of care. But what are some of the initial benefits? So there's been nice evidence that really shows that kids with ADHD who receive care from an integrated care approach have increased engagement and adherence with treatment plans, which really is great for us as providers and great for patients and families. As I mentioned, when we do integrated care, we're all together, we're using the same systems, and this really resolves many of the systems barriers that all of you experience when you're trying to get care in more traditional ways. So there's no more, I am kind of embarrassed to say, faxing of paper around, which is still happening in the medical profession much more than we would like it to be. We're not losing any papers anymore. We're commuting very seamlessly. Leslie can see everything that I see. Doug can see everything that I can see. So it really resolves many of the barriers that prevent us from receiving really good care. It really allows us to seamlessly respond to all your healthcare needs too. So no longer are your physical healthcare needs and your mental and behavioral healthcare needs being provided in separate settings, but they're being provided together in the same setting, which really improves the experience that we're all having. And there's really good evidence, several articles now that show both patients and providers have very increased satisfaction from these types of care models. And finally, in our experience, we really believe that we're able to make diagnosis earlier and more accurate using an integrated care approach. So I had mentioned at the beginning that we're going to use a case throughout our presentation to really try and pull everything together. So I'm going to introduce you now to Sarah. So Sarah is an 8-year-old that I've known since birth. She and her mom present today for a well child check. Her growth and development are typical for age. Her vision and hearing screen were normal. Mom filled out in the intake paperwork that Sarah has a well-balanced diet. She's getting regular daily exercise, and her mom indicates that she's been sleeping well. Sarah's mom did not list any obvious concerns or questions on the intake paperwork, but in routine behavioral health screening, she did indicate that her daughter is a little less interested in school than she used to be. Her grades have been dropping, and she's been having some struggles making and keeping friends. So as a primary care provider in kind of a traditional, or before we had integrated care, what probably would happen next is I would acknowledge those concerns and say, hey, we don't really have time to talk about that today. We schedule a follow-up appointment dedicated to those concerns. I would provide mom some screening tools, so probably a Vanderbilt for both her and teacher to fill out. I would ask mom to be responsible for remembering those papers, taking them home, getting them filled out, both by herself and the teacher, returning them to me, and making up a follow appointment. And all of that burden would really be on the patient and family. In an integrated care approach, actually, It's much different. So I would identify Sarah as, hey, Sarah may be good for enrollment in our integrated care approach. It's my job to identify patients who maybe would be a good fit for this model, introduce what integrated care is to the patient and family, briefly talk about the different roles of myself, the behavioral health care manager, and the child and adolescent psychiatrist, obtain formal consent to provide care in this way. And key to a lot of this is communicating with school. So I would facilitate getting a release of information to communicate with school. And then really uniquely, I would actually make a warm handoff to the behavioral health care manager, so to Leslie in my practice. And ideally, if Leslie wasn't engaged in direct patient care, this would be an in-person introduction. So Leslie would briefly be able to say hi to Sarah and her mom, introduce herself, and talk to them about what next steps would be, and then get that follow-up going. I would still initiate diagnostic assessments using validated screeners like the Vanderbilts. I would do complete exam today while I had Sarah, and I would round out the history. Ultimately, I would work with our other care team members to make diagnoses, to observe Sarah over time, and then to adjust the diagnosis as appropriate. Finally, I would work with the care team, including the patient and family, to develop a treatment plan, implement the plan, again, track over time and make adjustments as needed. If medications are indicated, I would do the prescribing. But unlike in the past, when I would do that kind of in isolation, I have the benefit of having the expert, the child and adolescent psychiatrist, to inform my medication prescribing. I would address any safety concerns, and finally, I'd monitor the patient's physical health over time for any potential medication interactions if we ended up using meds. But really, one of the key things is this warm handoff. And so that's what I'm going to do now. I'm going to warm handoff to Leslie, who is going to take us next and talk about what this looks like from a behavioral health care manager perspective.
Thank you, Sheryl. Yes, and today I'm going to be talking about the different components of a behavioral health care manager. And in some places where this is being established, that can look like a nurse or a psychologist. But for the sake of this presentation, I'll be coming from the point of a licensed social worker. And it's a very collaborative model, as Sheryl said, in the sense that in the past, I believe that MDs or people would hand it off to the care manager and ask the care manager to take care of all of those details. In this case, we're trying to work very carefully as a team and pull from all of the expertise of everyone on the team. And so when Sheryl mentions and sends a referral to me for Sarah, I'm going to do a few different things. And the things that I'm going to try to do are assess, identify, clarify the issues, connect and collaborate, monitor what is happening, and then also as a social worker, advocate and help families navigate systems. It's not always in that linear fashion, but for the sake of the presentation, I'd like to move forward in that way. So when Sheryl mentions a referral to me, or I get a referral from her, the first thing I'm going to do is connect with the parents. I am going to meet them in person, or most likely even follow up with them by phone. And I'm doing a number of things. One is to review the referral and review the history, gather medical records, look at the screeners, try to get an idea of what the historical issues are for this child, all the big picture, and to obtain permission from the families. And one of the things I'm trying not to do is make an assumption that I know what the families want to have done, or that I'm going to do what people think that I should do. I'm going to listen to the parent, and I really want to establish a relationship and rapport with those parents. I want to let them know that we are a team, and I want to hear what do they want. I want to outline goals and begin a treatment plan based on including them as part of a team. And that may be, some families may just want a medical perspective, while other families are not at all interested in medication. And in fact, they would prefer just psychoeducation. Some families already have a diagnosis. Some families are at the very beginning and don't understand what's happening with their child's symptoms or behavior, what's happening at home. And so I'm really trying to advocate with the parent and hearing their voice, and trying to be an advocate in partnership with the parents. While I'm doing that, we're looking at the screeners. And I'm thinking about, do we need other screeners? As I'm listening to parents, are there other concerns outside of ADHD? Am I hearing anything in the conversations around learning disabilities, or maybe autism or anxiety? But I'm keeping that in my process and in my thoughts while I'm assessing family and talking with them to see what would be the best next steps. I'm also asking parents, who should I talk to? Who knows your child best? Kids spend 6 to 8 hours a day in a school setting. So who at your school knows your child best? What other medical providers may be involved in the situation? Is there a neurologist or past pediatricians? Do you have a counselor? Has your family ever been in counseling? And at the same time, I'm also introducing our integrated program, and I'm discussing and introducing Dr. Doug Russell, who's our psychiatrist, not in person, but just explaining what the process is and how he may be involved in helping us determine what the needs are for that child. So this is a big component of the first step that behavioral health care manager would do. And I really like this visual because I feel like it captures what the next piece is that I'm going to speak more in detail about. While I am here in the center and navigating conversations with Dr. Morelli and Dr. Russell and maybe other providers in our clinic system, as well as the parent, I'm also extending my collaboration to the different areas that kids are involved with or families are involved with. Definitely school. Definitely we're wanting to be hearing what the school is observing, what they're experiencing, other community mental health folks that might be involved, and then also other community agencies, like I said earlier, other medical providers, early education folks, that type of person. I'm really looking to be the linchpin between the medical facility and the clinic and the child's life so that I can sort of see a really big picture and present it back to Dr. Morelli and back to Dr. Russell to help the family out. So that kind of brings me to connecting and collaborating, which really is the biggest part and what I think the really essential part of integrated care and what my role is as a behavioral care manager. It's so important to establish trust and alliance with parents, then to outline goals and to develop a plan and make sure that they know that we are hearing them. And it's also very, very important to network with schools and mental health professionals so that we can provide either evidence-based treatment or we can provide accommodations through any sort of 504 or IEP, and we can really help best fine-tune care for Sarah or a pediatric patient. While this is happening, I'm also having monthly meetings with the primary care provider, and we are checking in. And I'm also talking with Dr. Russell to navigate to let him know what's going on with Sarah. And so that he has not met Sarah yet, but he may be giving the PCP guidance or maybe giving me some guidance on how I can help the patient in that moment. At Kent Des Moines or University of Washington, one thing we're also doing is that we are looking at what's called social determinants of health and what barriers families may be having. So our team is asking families, do you have enough food? Do you have shelter? Do you have transportation? Are there language barriers or any issues around paying bills? And we really feel like that's a huge component to taking care of kids' mental and physical health. And so that's also a discussion that I would be having with a family so that I can understand and treat barriers in accessing care for families. Overall, what I'm trying to do is reduce the silos or the individual care that might be happening at the pediatrician's office and at this person's office and at the school, and really trying to get a very collaborative way to manage children's lives and children's mental health and behavioral health care. I'm also going to be at times providing what's called a brief parent-based, evidence-based training so that we can be teaching some skills to parents who may have some difficulties either getting to a specialty appointment or trying to provide some education right there in the clinic. That's short and brief. While all of this is happening, monitoring is happening. And I'll just be brief in this sense, because I think I spoke a little bit to that, but I'm really just sort of overseeing all of the different pieces that are happening. I'm monitoring collaborative relationships outside the clinic. I'm monitoring what's happening between Dr. Morelli and Dr. Russell and myself. And then I'm also keeping track of what's happening with screeners through through a registry and through care management lists. And so I'm really monitoring what's happening from on a big screen and seeing sort of how things are changing or if they're not changing. And if things are not changing, then I'm also addressing those concerns and troubleshooting as needed. And finally, I think, especially as a social worker, advocacy and accountability is really a big component of this program. I'm really wanting to, what I say, go to the mat with parents and really partner with them to find interventions that are effective, that are evidence-based, and to reduce barriers. I'm at times at the school with a family, sitting in a meeting to, help find that voice of how do we provide accommodations for children, or do we need an IEP? I'm educating parents on how to ask for those questions, how to advocate for their child. What are your legal rights? I am asking. I think it's really important that I'm available so families can reach me through the medical record or through the phone. And I really believe in, do what you say you're going to do. So I try to be reliable and really partner with the families and the medical team. And then I just support, encourage, cheerlead, provide hope, continue that. And in this case, when we go back to Sarah, while I'm doing all this monitoring and advocacy and accountability, some conversation comes up that, maybe there's some anxiety that's happening, or maybe we need to look at a screen for anxiety. And at that point, that may be where I would pull Dr. Russell in the sense that if a child has been receiving care from Dr. Morelli but isn't making progress, or we're seeing something new that we're not quite sure, or we need some more detailed diagnostic intervention, I will then ask Dr. Russell to come in and help us out with doing some clarification, and I will pass the warm handoff to him, and he can explain his part.
Yeah, thank you, Leslie. So I'm at this point in Sarah's journey. I've already had one or two, sometimes more, conversations with Leslie. Sometimes we've already had a chat with Sheryl as well about the case. And in Sarah's case, we've discovered that there is this anxiety piece that's come up, right? Anxiety is one of these great mimics, especially when it comes to inattentive symptoms for ADHD. And so we discussed that and determined, hey, we need a little bit of help with diagnostic clarity. And so we decided that we'll schedule Sarah and her family to come see me for a one-time visit. And that's a 90-minute visit. So this is a long visit. It's an opportunity for me to really take a deep dive in the history and get into some aspects of Sarah's life and Sarah's care that Sheryl hasn't necessarily been able to access yet. And all of that is built around the incredible work that partners like Leslie have done. Right? They've already created a connection with the family. The family is not surprised when they come to see me in my office, and we can really work collaboratively. So what I'm going to do over the next few minutes is I'm going to sort of pull back the curtain a little bit on how I operate as a child and adolescent psychiatrist within this model. And this is a painting from the 17th century, and it's incredible. I found this photo. It's like an exact replica of my office at Seattle Children's. Just amazing. Before we get into more details, I'd like to spend just a minute explaining the difference between psychiatry and psychology, because particularly in pediatrics and in integrated care models like this, you might encounter both professionals within the same system. And it's really confusing to parents. They're spelled nearly the same. We're often doing the same type of work. So psychiatrists like myself, we take more of a medical route in terms of our training. We go to medical school, then we do a residency in adult psychiatry, and then in my case, a subspecialty fellowship in child and adolescent psychiatry. And what this allows us to do is get training both on the medical side. We can prescribe medicines. We have a familiarity with complex or chronic medical conditions and how they impact psychiatric conditions. But we also get psychotherapy training. And are able to deliver evidence-based psychotherapies to kids. Psychologists take a different route. They get a PhD. And so they oftentimes that route is a little bit more research focused. But there's an avenue that psychologists can take called clinical psychology where they get a little bit more in-depth training with the delivery of evidence-based psychotherapy models. Usually in this day and age, most of those are around behavioral, CBT, DBT, things like that. And we often work in the same systems, and they're excellent collaborators. And we're fortunate at the University of Washington to have faculty from both disciplines working side by side. All right, so when I'm preparing to see a family, what are the things that I'm looking for? What are the things that I need to be efficient and to really meet the family's needs? Well, first, I want to review the case with Leslie, right? I want to get a sense of, what are the structural and social barriers? What are the nuances of this case? Have any screeners been done? What do those show? I'm, of course, also going to read Sheryl's notes. Those are accessible in the electronic medical record. We're all in the same system. And, I may also, we're in the same physical location too. I may take her aside and say, hey, I'm going to be seeing Sarah next week. What are your thoughts? Love being able to do that. As I mentioned, I'm going to review any standardized measures that have already been done. And I'm going to think about, are there any more that need to happen? And probably most importantly, is I want to get a sense of what the consult question is. How can I be most effective for this family? So to do my job well, I want a clear consult question, right? How are we going to use this 90 minutes to be useful? I'm going to review symptom measures. Because I'm an MD and we may potentially be talking about medication treatments for ADHD, it's really important for me to have detailed information about medication trials. And boy, when parents come with that list, telling me the agents that have been tried, when the child took them, the response to those, boy, is that so helpful for me to have that all in one page. And then we can spend more time on other aspects of care. Equally important to the medication trials or any psychosocial interventions that have already been tried, right? Any psychotherapies, is there an IEP already in place? Are there academic supports that have been successful? And of course, knowing the specific stressors that the families are experiencing in their lives that may impact access to care or their ability to follow through on some of the recommendations that I might imagine might be helpful for them. All right, so back to Sarah. So what's the consult question here? Well, I think the big question that we want to answer is whether, hey, is this ADHD or is this anxiety or is it both? Right? Where should we prioritize our treatment? In terms of measures, prior workup. Because Leslie is such a skilled partner, she's often talked to schools. She's helped the family gather Vanderbilt assessments. And she's also added on SCARED measures, that's a cute acronym for one of our symptom measures that focus on anxiety symptoms. And I have those in front of me, right? And I see in looking at those that Sarah has a lot of inattentive symptoms, not so much hyperactive symptoms, but parents and teachers both recognize that. That's a really important piece of information for me going into the consultation. On the SCARED measure, there's some certain aspects of anxiety symptoms are also elevated. She gets somatic symptoms are related to school. Somatic symptoms are when anxiety is experienced in the body as a stomach ache or a headache, something like that. That's noted on there. There's a little bit of school avoidance that's noted on there too. I take note of that. She hasn't tried any medications in the past, and she hasn't accessed any formal psychotherapy modalities, though she has started to see the school counselor. Her school actually has a school psychologist, which is great. And they've started meeting a little bit, noticing that she's starting to struggle a little bit. Other important history. The family recently changed schools. Okay, this is a stressor for Sarah. And I also learned that Sarah's mother is a single working parent. All right, so I'm going to take my opportunity to meet with this family to take an even deeper dive. And a lot of times these kids and these families, kids especially, they come into these appointments, oh, brother, I'm going to talk about, my problems at school. I'm going to talk about my behaviors at home. They kind of come in downcast a little bit. And so I like to right away sort of flip the script a little bit and make sure I know what the strengths are of this kid. And I find out that Sarah is a really talented gymnast. Right? She's also very creative. She loves art and she loves building things. She loves working with her hands. ADHD is just about as heritable as height. There's also, it's also super common, as Sheryl mentioned. So why is ADHD still around, right? We've been humans on this planet a long time. Why hasn't it been, if it's so bad, why hasn't it been cut out of the gene pool? Well, of course, it's not so bad. There's actually some advantages associated with ADHD, but sometimes modern schooling is just one of those situations where kids really start to struggle. Inattention in Sarah first noticed in kindergarten. That's when the teacher started to indicate that she was struggling a little bit. She's 8 now. She's struggling academically, but for the most part, she's at grade level or almost at grade level in most areas. However, she's starting to show some significant impairment around math concepts. And that's something that's highlighted on the Vanderbilt form that the teacher filled out. She's starting to compare herself unfavorably to peers, right? You're starting to see some cracks in the self-esteem. That makes me start to think about mood concerns as well. And I'm gonna, in that visit, I may do a short mood and feelings questionnaire to kind of get at those depressive symptoms and see if there's anything that I need to be concerned about there. In this case, I determined that there really isn't an active depression happening right now. There's not a major depressive episode. However, you can tell that Sarah's starting to get demoralized, particularly around school. In terms of her anxiety symptoms, those seem to be pretty restricted to school, and especially to activities around numbers tasks. She's really avoidant when she does homework around mathematics, and is starting to feel nervous about going to school because she's recognizing that she's struggling a little bit. I take a deeper dive with sleep symptoms problems as well, and I notice that although mom noted that she was sleeping well, with a little bit more questioning, we noticed that she's having a little bit of problems falling asleep and is waking up a couple of times during the night. And that's starting to become noticeable to Sarah. Family history is so crucial to what I do. I mentioned that ADHD is almost about as heritable as height. Well, there's a family history of ADHD that's known in the father. And I also learned that mother is recovering. So there's a history of substance abuse in her life that she's moved past. Whenever, and she also notes that her mother struggled in the same way. So Sarah's grandmother. Whenever I hear about multi-generational functional difficulties or multi-generational problems or multi-generational traumas, right? I always start to think about ADHD, right? What were these kids' experiences in school, right? Was that somehow informing their problems as adolescents? All right, so let's put it all together now. I got a lot more information. Again, I started with a great sense of Sarah and this family with working with Leslie and reading Sheryl's notes. And I determined that that Sarah doesn't really meet criteria for an anxiety disorder per se. There isn't really any generalized symptoms. They seem to be pretty restricted to aspects around school performance and what she's noticing as she compares herself to peers. However, there's clear inattentive symptoms both at home and at school. When talking to the mom, I get a good history there, and it's also represented in the collateral information that we've gotten from teacher, both the information that Leslie has gleaned by talking to the teacher over the phone. So amazing to have someone like Leslie who has connections to the school districts in the area, who can just pick up a phone and get so much personal information that's relevant to our patients and their families. I have some concern about this mathematics and problems that she's experiencing, and her issues around numbers makes me wonder about whether there's a specific learning disability here, a specific learning disorder in the area of mathematics. Specific learning disorders, up to 45% of kids with ADHD also have comorbid learning disorders. That's not something we want to miss, right? So I'm going to recommend that they pursue psychoeducational testing through the school, so we get a better sense of what Sarah's cognitive strengths and weaknesses are, and also whether there's a specific learning disorder that might require some more specialized instruction. In her case, I'm going to consider a stimulant trial. So ADHD is one of those conditions in psychiatry. It's a little unusual in that we usually combine treatment with medications, with psychosocial treatments from the get-go. So I'm going to start to have that discussion. I'm going to go through the risks and benefits of a stimulant trial with the family. I'm going to allow them to think about it. I'm going to give them extra information about it so that when they visit with Sheryl, usually in a couple of weeks, that visit is automatically scheduled after my consultation so that they are able to right away continue this conversation with Sheryl. And they're going to be prepared for whether or not they want to pursue that treatment off. I'm also going to consider a referral for parent behavioral management training because in the history I learned that there's starting to be the relationship between mom and Sarah is starting to fracture a little bit because of the concerns around school performance. I'm also going to take the time to investigate and talk a little bit more about lifestyle factors that can impact attention, and in particular, sleep hygiene, right? Ways to support Sarah's sleep. Also, we'll talk a little bit about diet and the things that you can do to promote attention and focus using dietary choices. As well as emphasizing how important it is that she's a gymnast. That's great. She's getting physical exercise multiple times per week. Love that. And when I write up my note, right, when I write up my note for the medical record, I know that this is just a one-time visit with me. So I'm trying to anticipate, right? If for instance, there's a stimulant trial and there's side effects associated with that stimulant trial, what happens next? I'm always thinking about those next steps so that Sheryl and Leslie have a bit of a roadmap to follow in the subsequent visits with Sarah. And one of the beauties of this model also is down the road, Sheryl can just pull me aside and say, hey, remember Sarah? This is where we are now. Or Leslie can do that too when we're reviewing the cases. This is where we are now. What would you recommend from here? All right, so at this point, we're closing the loop, right? We're all communicating with each other, and the patient and the parent are in the center of that triangle, right? They are involved in, they've interacted with all of us. We're interacting with each other to support this family. All right, now I'm going to pass the mic back to Sheryl. I think Sheryl might be taking the next.
Yep, I got it done.
Sheryl. All right.
Yeah, so I talked a little bit about benefits early, some that in the literature, in the research literature that really has supported integrated care models for the treatment of ADHD. But, Leslie actually helped to make this slide, and I think she chose these words, and I really like them, that this really this is creating efficiency, personalization, and optimization. So what great words, right? And that really does. Integrated care really creates a much more efficient process for all of us, for the patient and family, for the schools, for myself, for Leslie, for Doug. So this is a much more efficient way to receive care. It's much, much more personal. So, as Leslie pointed out, she really tries very hard, as do all of us, not to come with any preconceived notions of what's going on with the parent and family and what you guys want and what you need from us. So really being able to personalize this for each patient really is a huge benefit, and really then to optimize, right, the resource. So, I think that one of the bullet points here says, this is incredible in that it allows all of my patients to have access to a child and adolescent psychiatrist. That's incredible. If I tried to refer all my patients to Doug for care, it's a 9, 12 plus month wait, and some kids absolutely would never end up engaging with a child and adolescent psychiatrist. And this allows for everyone to benefit from that expertise through me and Leslie, which is really an incredible opportunity for our patients and families, and a way to really use a scarce resource to reach as many kids as possible. This really allows patients and families to receive care where they typically already are comfortable and they already have established trusting relationships in their primary care home. We believe this provides much more accurate diagnosing, as well as identifying any comorbid conditions, which we know are very common with ADHD. This absolutely improves communication and collaboration, in particular with schools, which Leslie is quite skilled at, and that really has been a huge game changer for us, patients and families, to navigate the systems to help improve outcomes, but also just to get the communication lines flowing at the beginning. Job satisfaction, I can say for myself, has absolutely improved. I believe it has for Doug and Leslie as well. There's some nice research that showed that is true. And Leslie's heard me say this many times in presentations. I would never practice now in a clinic that didn't have an integrated behavioral health program. So that's definitely been a game changer for me, and I feel it's been a game changer for our families and patients that are receiving care from us, who really now are getting the evidence-based care that I feel they deserve earlier with more accurate diagnosis. So I'm sold, and I hope that after this, you guys will really be sold in considering these types of approaches as well. I'm going to turn it back to Leslie real briefly just to talk on, well, how do you get started if you're interested in this, if there's professionals out there interested in this, or patients and families interested in advocating for these kinds of approaches in your community.
Thanks, Sheryl. When I walked into Kent Des Moines 10 years ago, I like to say this, they all kind of looked at me and said, we really, really need you, but we don't know why, but we really need you. And we really started from a baseline of, like, what are we doing? How can we better help these families? And I was getting calls from schools. My 6-year-old is climbing the bookshelf and banging his head on the window and biting a teacher. And we had families telling me, our pediatrician wants to prescribe a stimulant, and that's not what my gut is feeling like the right thing to do. Maybe there's something else going on. And it was just really sort of this big, and I still get that 10 years later, like, people present and are, like, we just don't know what to do, or, we need some guidance. And I'll say, to get started, really, I started out with outreach, get to know people in the community, get to know the school personnel, get to know everyone, because right now I can tell you that schools now call me. They now call UW and say, I can't diagnose, but we have a family who's looking for medical care, and we know this program works. And school teachers and professionals, psychologists, counselors like the collaboration. They look forward to the collaboration, and they appreciate the partnership. They're appreciating not working on their own any longer. And I believe that takes the parent out of the middle when MD saying, talk to your school psychologist, and the psychologist saying, talk to your MD. And then the parents get kind of stuck in the middle. We are developing workflows, and we're always fine-tuning them. I saw someone ask about payment. That's always a question we get. And I can say briefly, in Washington State, we do now start to bill for collaborative care codes. So we are examining how do we do this, and also, support this process financially. I won't get too much into that, but I did see that question, and we have moved in 10 years to that. So it is possible. Again, be reliable, be accessible. I'm the person people can reach easier. You can't call Dr. Russell or Dr. Morelli on the phone. You can call me. I can get your message to them. We can partner together. We can get back to you. You have a support person. You have a medical home. Collaboration. It's not about the doctor giving it to Leslie, and then Leslie, you go do all the work and get back to us now and again. It's Dr. Morelli, this family's struggling with this. Can you help me with this? Dr. Russell, this med's not working so good. They don't need to come in for an appointment necessarily. We can collaborate and decide if an appointment is needed or what we can do to fine tune things. I've learned so much working right next to doctors, and I'd like to think that doctors have learned a lot from me too, in how social work works and how we can be collaborative. And so we all learn and we all grow. And I've seen medical folks start to educate parents about this is how you reach out for an IEP, and this is how you reach out for a 504. This is how you get parent behavior management training. And I believe really strongly and passionately in this program in the sense that it really works. And I feel like I get really amazing feedback from the families that we support.
So I'm going to wrap up real quick with some key take-home points, and then I think we have some time to address some of your questions. So, unfortunately, the shortage of pediatric behavioral health professionals is going to continue for probably the foreseeable future. There's just not very many of them. Our training programs are increasing, who they're turning out a little bit, but it's going to take a really long time before we really have enough child and adolescent psychiatrists, psychologists, developmental pediatricians to really be able to see all these kids. I hope that we convinced you primary care really is the ideal setting to initiate care for behavioral health conditions. We really feel like we have the longitudinal trust relationships with patients and families to be a successful setting for this. Integrated care models absolutely emphasize collaboration, efficiency, and accountability, which we feel are essential to patients and families receiving the care they need. And absolutely, there is good evidence that these evolving models of behavioral health integration really are having a positive impact on children and adolescents with ADHD, as well as their families and the schools. So I agree with Leslie. We all feel very passionate about these models and really believe in it, and hope that you guys actually have some nice takeaway points from this presentation. So I think now we have some time for questions.
Fantastic. Thank you all so much. My notebook is full. So before we get to questions, I want to very briefly thank Brain Balance once more for sponsoring this webinar. The number one question we are getting today is about how rare is this model? Now, if I understand correctly, sort of the connective tissue here is the University of Washington and building this integrated care model. Are you breaking new ground? Are there other models similar throughout the United States and even internationally? And how can people find a similar model near them? These are the top questions.
I'm happy to start, and then I think Doug and Leslie can probably chime in. I have a pretty good sense. So I belong to a learning collaborative of other pediatric networks similar to ours across the country. And I will tell you, this is becoming common around large children's academic medical centers. So if you have a large children's hospital in your community, and again, big cities, Chicago, Philadelphia, Seattle, et cetera, probably there's something either being developed or already being offered in those clinics. But once you get outside of large pediatric academic centers, this is not standard of care yet. It is much more common in adult practices, both in out in communities as well as closer to academic medical centers. A lot of this work started on the adult side and has been adapted into pediatrics. So if you are fortunate enough to live near a big children's hospital, yes, you probably can approach that children's hospital's primary care practices and just ask them, do they have behavioral health embedded in their pediatric clinics? If you are not near a big city, or you can absolutely talk to your pediatrician's office about, hey, have you considered collaborating with any of the behavioral health professionals in your community? Because really all it takes is having a pediatrician interested, a behavioral health provider interested. And you really usually can then tap into a child psychiatrist because they don't have to necessarily be there in person. And so I don't know if I could talk about this for a long time, but we might want to get some other questions. I don't know if Doug or Leslie, if you'd add anything to that.
Yeah, no, I agree with you, Sheryl. I think this is a model that's increasingly known, but yes, it seems to be mostly around those larger centers. And I think part of that has to do with funding streams, right? Academic centers are able to pursue grants and things like that to get these things started. Increasingly, though, as Leslie mentioned, there are innovative strategies in a lot of states to get this stuff paid for using new codes and stuff like that. So I think the future is bright. The other thing I wanted to mention is that, the model that we talked about here is a common one in clinics, but there are other collaborative care strategies that people have tried that work differently. For instance, there's a telephone-based consultation model through Seattle Children's called the Partnership Access Line, which is based on a similar program out in Massachusetts. And it's designed to just essentially provide brief telephone consultation to pediatric providers in the WWAMI region. So that means Washington, Alaska, Wyoming, those states and those areas where there isn't integrated care available, where there aren't any, there's not just a shortage of pediatric behavioral health or mental health providers, there's none. And so those models sprang up to help pediatricians care for these kids in those areas, and those have also been successful in their own way. Not nearly, of course, as comprehensive as a model like this, though.
And the only thing I would add is I'm a social worker, right? I'm an advocate, and I'm going to push the envelope. If I were a parent listening in on something like this, I would most definitely encourage parents to be talking with the providers that their kids are seeing, talking with their teachers and their counselors, and asking for collaboration or consultation, and just seeing if you can get people talking.
Excellent. We hear a lot here at ADDitude, especially over the last 2.5 years, actually, that many adults are diagnosed shortly after their children are diagnosed. And someone wrote in today to say that they found that family dysfunction is a big barrier to care when the parents have ADHD, but it's not been diagnosed. Can this integrated care model help on that frontier as well in helping the parents or caregivers to get the care they need to do the best job possible for their children?
Doug, I see you smiling and I'm smiling. So do you want to speak?
Well, yeah, I mean, I mentioned how heritable ADHD is and it runs in families. And, this is an opportunity. I think my role when I'm seeing a family is to really take a little bit of a deeper dive with that family history. I see children, but what I really see, and I think Leslie would agree with this, is we see families, right? We see family systems, and ADHD often impacts more than one individual in that system. So if you can increase recognition about that and point an adult parent who maybe suspects, oh, hey, I'm seeing a lot. I was just like Sarah, when I was a kid. I had a really hard time in school, but I was quiet. I wasn't I didn't have any behavioral problems. I just sort of slipped through the cracks, right? So you can identify that history in the parent as well. And sometimes if the parent gets treatment, boy, that family system really starts cooking, right? It starts, the relationships start to heal. Parents are better able to access the behavioral strategies, the parenting strategies that they learn about. It's funny. We have a study right now at Seattle Children's looking at the treatment of parents of children with ADHD, where we diagnose the parent. We provide treatment to the parent, and then we determine how that treatment is impacting the child. So, that's definitely a hot topic, and one that I think a lot of people are exploring.
And I would just jump in. I was going to mention the study that we're involved in where we're treating parents to see the impact on the children, but it's also about like normalizing and educating families and maybe breaking through that stigma that Sheryl mentioned at the beginning, and really just having someone to talk through that. Like, oh, I never noticed this about myself. Leslie, do you have any ideas of where I can go? I know I'm not your patient, but do you have ideas of where I can seek out treatment or my own primary care physician? And that is absolutely what integrated care can do for families.
Yeah. Excellent. And oh, I'm sorry, please go ahead.
Oh, I was just going to say, it's so powerful for a child who's experiencing attentional difficulties, who's feeling kind of like out of place and alone in this. It's so powerful for that kid to hear from their parent, oh, I had that same struggle as you. Because then they can say, well, hey, my mom's okay. I'll be okay too. So we definitely encourage that level of dialogue.
Wonderful. And you mentioned this, I think, briefly in the slides, that you've seen that the treatment plan is more likely to be adhered to in this integrated model. And I would assume that when the parents are also having their symptoms addressed, it's only going to improve the consistency of care for the children as well as the parents. So it seems like a win-win.
I think I could just add one brief thing as well, because I'm monitoring alongside the medical team. People will fall off. I'm monitoring multiple families at the same time and doing other pieces of my job. But the registry reminds me, oh, I haven't heard from Sarah's mom in 3 weeks. She was supposed to get back to me on this, Vanderbilt or what have you. And I recognize that kids who have symptoms of ADHD or ADD may have someone in their guardians who have the similar symptoms. So I'm going to reach out and I'm going to take the my own direction to reach out and say, hey, where are we with that process, and help with that process without placing judgment or saying, geez, she never got back to me, so guess I'm not going to do any more with this kid. It's just more of like reminding, the registry reminds me to go back and kind of close the loop and make sure that things are moving forward if that's what the parent would like to have happen.
That makes sense. Well, I'm sorry to say that we have run out of time for today. I would like to quote just one of our listeners today. She said she's a neurodivergent mom of 2 neurodivergent adolescent girls. And she says that this concept sounds like an absolute godsend. So you have educated people and given them a lot of great resources to advocate for themselves and their families. And we're very hopeful that the integrated care model will be discussed widely among ADDitude listeners and their caregivers in the coming weeks and months. So thank you so much for leading this conversation. I want to invite everyone listening to join our next free webinar from ADDitude on a totally different topic. It's on maladaptive daydreaming and ADHD, important similarities and distinctive differences, being led by Dr. Nurit Sofra-Dudek. And that is next week. To make sure you don't miss any other ADDitude webinars, articles, or research updates, please visit attitudemag.com/newsletters and sign up for those alerts. Thank you again for joining us today. We hope to see everyone again soon.